Hi, folks. We're going to give it just a moment before we officially start, but glad to see folks coming in. Once you are set here in the Zoom, if you want to put in the chat your name, where you're coming from, maybe your connection to this topic, that's always really helpful. You can use the chat box for that. I know our speaker today is curious about folks' roles, and it's always nice to kick off some introductions in the chat. So again, we'll give it just another few seconds to let folks keep coming in and typing in the chat as well. But just for the sake of time, and while folks are doing that, want to say again, hello and welcome. You can feel free in the chat if you want to use the drop-down box and select everyone. There's also an option for host and panelists, which you're welcome to use if you have any technical questions or any needs. Thanks to those who are starting to put their info in the chat. So again, officially, hello and welcome to our webinar on improving end-of-life care for community-dwelling older adults. My name is Ariel Mather, and I'm the Senior Program Manager of the National Center for Equitable Care for Elders. We're very pleased to have our wonderful subject matter expert here with us today. I'll get through housekeeping very quickly so we can go to all of the great content. All right, I'm sure everyone's very familiar with Zoom at this point, but we always like to have a few reminders that because this is a webinar, folks aren't able to unmute, but that doesn't mean we don't want to hear from you. You're able to use the chat clearly. Lots of folks are introducing themselves. Wonderful. You can also use the Q&A feature if you have a specific question for our speaker today. We will see how much time we have at the end. We'll try to get to as many questions as possible. This session is being recorded. I know folks usually have questions about if they can have access to the slides. We will make sure everyone has a link to the recording and a copy of the slide deck within the next week. So look out for that in your email. And we always use a quick evaluation link at the end of webinars like this. Really helps us to shape future learning opportunities. So I encourage you to take a moment at the end of today's webinar to share your thoughts. All right, if you are not familiar with NCECE, we have been providing training and technical assistance to health centers and lookalikes, community-based organizations since 2017. Our focus is, as our name suggests, community-dwelling older adults. We have lots of ways to stay connected with us. We actually have quite a few upcoming learning opportunities. I think the next slide indicates one of those things. Yes, thank you, Juliet. So in just a couple of weeks, we have a webinar series starting. This is actually, I think, a great, if you haven't interacted with us before, this webinar series linked on this slide, which Tiff will also put in the chat, is a great, I think, foundational learning opportunity around ways that we can improve primary care for older adults. There's a lot of different paths that we'll discuss in this series. So I encourage you to check that out. And like I said, the previous slide has a lot of contact information. We'd love for you to sign up for our newsletter and stay in touch with us. Yes, all are welcome to register. Thank you. All right, we always put a quick plug here for the Health Center Resource Clearinghouse. We have lots of other fellow training and technical assistance providers, and this calendar is a great sort of one-stop shop to see other free learning opportunities available to health centers and community-based organizations. So feel free to check that out. All right, very quickly, everyone saw the learning objectives when they registered. There's a lot of great content today, and I know that our speaker will give a little bit more context about her background, but I will do a very brief introduction. Great, thank you so much. So Dr. Lynn Hollerman is no stranger to our center. You may have been in learning opportunities before where she has spoken, but She has 3 decades of experience in internal medicine and as a palliative care physician. She is now a journalist. She is a consultant for us in a lot of activities. There's contact information. There's a link to her website on the slide, but Tiff will also put a link to her website in the chat if you want to see some of her recent work. But we are really pleased to have her with us today because this is a topic that we've been able to generally palliative care we've been able to touch on in a lot of different ways over the years in our training, and we're really excited to have this focus on improving end of life care. So I will hand it over to you, Dr. Hallerman. Take it away.
Okay, next slide. And you can skip over this one too. Okay, so welcome everyone, and thank you for getting on in the middle of your workday. I know everybody's super busy. What I'm hoping is that you're going to really leave the webinar feeling sort of refreshed and energized, because I know this is hard work, and I'm well aware of that. So I'm just hoping you're going to come out feeling sort of buzzed, that you have some tips and tools to apply in whatever setting you're in terms of palliative care and hospice and end of life. All right, so let's get started. So here are the questions for the day. The term, end of life, I would call it a very loaded term that I can tell you I have never actually said to a patient. And probably it just doesn't work to do it. I always find it very, someone says, oh, the end of life doctor is going to come talk to you. So I really don't use the term except in a situation like that. And that'll become clear as we go along in the webinar. Um, when is it most appropriate? Okay, there's a spoiler alert here. Like, there's really no magic time when to have an end of life discussion. Some of the really worst times to have one is in a crisis in the ER, which is where that's when I get the call. And so some of this is about doing some, thinking about this preemptory, thinking about all this before someone's in a crisis. That's a role that all of you can play. Um, outside of hospice. And the other thing I want to just touch on is I want to leave you with some really good basics on how to open up a conversation like this. Because I mean, I always remember feeling just sort of nervous, a little bit, broaching a discussion like that. So you kind of need some ways to get into it. And sometimes that's all you need, is to get into it, and then it'll kind of flow from there. So that's what we're going to do today. We're going to look at these basics. Okay, next slide. All right, so I just thought I'd tell you a little bit about me. This is actually a really old picture at this point, but there's me and my team. It was a hospice that I ran for a number of years at the VA Maryland healthcare system. These are my colleagues. What's the people missing from this picture? We had like a phenomenal social worker and a chaplain that were part of our team. And I'll say that, you know, I didn't realize quite how special that situation was until I left it. But I think now when I look back on what I was able to do at that time, just to really focus on the patient care and the patient right in front of me, like it was just a great time for that. And at the time, I had come from the world of primary care. I had about 8 years as an internal medicine primary care doc. So the people in this picture are the people that I learned the most from about this job. And the point I want to make to all of you about hospice care and is simply that it really depends. It's really tight teams work best, is all I can tell you. And when I mean, we use the word interdisciplinary care a lot, but what that really means is that you're actually meeting with each other and talking real time IDTs. You know about the meetings that you have with your colleagues about a patient. In this case, we actually used to round together every day. Our whole team would round, and I have like great stories about all of that. One of them is also just simply that to try to have you have to have humor in this field, and I just want to remind everybody of that, because it's just so hard, and there's just lots of ways to bring in life and laughter into a situation. And I noticed there's a lot of volunteers on this talk, and I'm so psyched about that, because it's such an important part of hospice care. And in this one back then, they were very critical. We had a veterans organization that would, I would say something like, I need a uniform for a Korean War vet. He wants to die in his uniform. And then boom, like next day, we'd have the uniform. Or I have a Vietnam vet, he wants to have a shot of vodka and smoke a cigarette with another vet as his last dying wish. Boom, next day, the volunteers, we had the vodka, we had the cigarettes. Of course we had to take the oxygen off, but we did fun things like that. Patients actually can be quite funny in their own if you allow that to happen. So it's just a little bit of something I wanted to throw out there about sort of an attitude towards hospice care in general that really got me through it. And I think helped patients as well, patients and families. Okay, next slide. All right, so I have this one up here is just another kind of looking back on it as a time I actually ran a hospice. After I did that for a while, I actually ended up at Stony Brook Medicine, where I ran an inpatient, developed and ran an inpatient palliative care program for about a decade and a half. So that was a very different environment than running an inpatient hospice. But one general thing that I've learned through the years is people wrap around end of life in all different kinds of ways, depending on their personal beliefs, their religious beliefs, their cultural background, a lot of things. And it's just super important to just really have, I'll say, forgiveness and grace about where people are with all of that. And we don't try to have too much of an agenda about that, because I know it can be frustrating actually watching a family or patient who's just not getting it, like they're not on our go to the light schedule, we used to say, they're not doing what we want them to do. And it's super important to have an awareness of those feelings when you have them, or whatever pressures that you have in your group that are pushing you to other agendas. Hospice has a lot of pressures on it now that it didn't have when I was doing it. It's become commodified, and there's a business model that people are thinking about a lot of times. So you can have pressures, but at the end of the day, if you can kind of be aware of those pressures and kind of set them aside when you're actually dealing with patients, it's just a really good exercise to remember to do when you're around. And that's true as a volunteer, it's true as a clinician, as it's fluid in leadership to just kind of remember about that. Okay, next slide. So I'm going to zip through. I have some graphs. This is nothing new for most of you to know that we have an aging population. And if you look at the community health center bucket, you're going to see just more a shifting towards older adults in that population. And I just wanted to just remind everybody of that. Probably something you already see in your own practice. Next slide. This is another one I'm going to whip right through. But what I want to people to note about this slide is this is like a pre-COVID, post-COVID. I think the data is probably a little sketchy. That I got them. If you want to actually look at the report, you can go to the link at the bottom there. But this is really reminding people that not very many people die in inpatient hospice. It's really a small, that purple bar, the 8% at the top. So out of all the places people die, which I wish more people had a chance for that. It's just the inpatient hospice, is probably many of you know already. It's just got pretty strict criteria. You have to have symptom management, and it tends to be really quite at the end in order to get in one. So a lot more, I would love to see more people have access. And then also, as you age, your chances that you're going to die in a nursing home go quite up a bit. Like, so above 85, you can see the number of people dying like in long-term care are going up. And you imagine that people are entering long-term care, downstream of dying, maybe a year or two, and then they die in long-term care. And that's much more likely as people age. Next slide. Okay, so this also, probably this data is just a little bit sketchy. Just keep that in mind, not to take it too seriously. Um, but what I just wanted to remind people here is simply that it's funny, when I was looking at these numbers, I was thinking, okay, what about those poor people that don't have the hospice program who are dying at home? I was kind of wondering what kind of death they had, because I found it a little bit scary, accidental deaths or sudden deaths, things like that. But the other thing I just wanted to remind people about home hospice is that the whole model is works around these invisible caregivers that we kind of don't talk about a lot, and those the family members or the workforce that needs to support home hospice in order to get home hospice in the first place. So you really need to have a pretty intact social structure, or you need to have someone in your life who's willing to support a home hospice. And the whole model is based on that, and we kind of forget that. We kind of leave that group out. And I just want to give them a shout out, that invisible workforce that actually makes it possible for people to die at home when they want to be at home. Okay, next slide. Okay, we're going to do a case study. All right, so this is Carlos. Let me just tell you a little bit about Carlos. He's 75, he's new to you. He lives his life situation as he has a long-term partner, Julia. He has an adult son who lives in another state. He has a sister that he talks to a lot who has a lot of chronic illness, who's older. And then he has kind of a plate of issues that are very typical: some diabetes, high cholesterol, high blood pressure, chronic obstructive pulmonary disease. And so the question I have for all you experts out there, if you want to put this in the chat, go right ahead. If you want to feel, proud, there's not going to be a prize or anything. But if what is actually missing that you might think would be important to know about Carlos that I didn't put up there, so you can put it in the chat, just for kicks and giggles if you want to, and then we're going to go on for now. Okay, so we're going to just start with this question about, you know, when is adult, what is this term end of life? How do you know when someone's at end of life? Okay, so this is a lot of people might be familiar with this graph. It's kind of famous in the palliative care world, but it's really about what we call the disease model of end of life. And basically what it says is that, and let's just use cancer as, because cancer is the easiest one to look at. Someone gets a diagnosis of cancer. It's not a curable cancer, but they're a candidate for lots of treatments that can keep them going for a very long time, maybe even years. So at the beginning of the illness, like, which is represented by the purple at the top, they're going to be getting what we call a lot of life prolonging treatments. And then what happens over time, if it's an incurable cancer, is those treatments start to have less effect on keeping the cancer at bay, and you start adding more supportive treatments or palliative treatments. And at the beginning, that could be some pain management. I did a lot of this because I was part of an oncology division where I was supporting people through a difficult treatment where I would be helping with pain or nausea that was particularly bad. But as time goes on, those treatments can get more intensive and you start moving into what we call the palliative arena. And doctors use this model a lot because what they're basically will do is look at scans and then they'll say, well, the treatment I'm offering is at end of benefit and it's time like for hospice. And that can actually be pretty abrupt for some people. And that's why there's sort of that sliver of black at the end there, because the time people spend in hospice is actually pretty low. I don't know the recent, someone in this land out here might know the recent numbers, but I think it's like 7 to 12 days or something in a hospice program for home. So it's not a long time, but that just sort of gives you a sense of the doctor, the approach. They just look at end of benefit of a treatment, and then you get this increased in palliative treatments. Next slide. I just really like this quote. We're going to talk about this author a little bit, but she says, hospital stays that fix the acute problem and worsen with the chronic ones, with the dying humans. And it's just so true. I mean, it's so true the way things are, and especially my experience taking care of hospitalized dying patients, I found this to be true a lot. And let's just unpack that a little bit so you can go to the next slide. This is another slide some of you might be familiar with. It's also another famous one from Rand. And what it's doing is, this is the way that I have always tended to look at patient care more through the lens of function. There's the disease model where you're looking at end of benefit, and you might be doing that with an oncologist or some other doctor. But for palliative care, I'm always starting with function. It's going to be your most useful tool in terms of of sort of understanding people's lives and where they are and what they need, actually. So if you could see, you have function over time. And at the top, the cancer trajectory is actually one of the easiest ones to see. Oftentimes what happens is you have someone who's doing pretty well, on the functional curve, getting treated. And then at some point, the disease can kind of it starts to rapidly increase suddenly. and then they will sort of just get swept away functionally and move towards death rapidly. And if anyone who's been through it, that you could see that happen over weeks or days after a period where people have been really quite okay. Um, the second bucket there, which is like COPD and heart failure and so forth, that can be a rough one. And I actually got a lot of calls for this one as a consultant because this can happen over many, many years, and families tend to move in for caregiving slowly over time with this trajectory, and they don't quite recognize that they're doing so because they're just living their lives and they're supporting, and they're adding support, and they don't always notice the change in function. So you have someone come into the hospital, that's that dip in the curve with like a pneumonia or an exacerbation of COPD, and they get better, but they come out like slightly functionally less, meaning maybe now they have oxygen, they're oxygen dependent, or they need a walker, or something's changed in their function that people, families, and patients adjust to because people are basically resilient and they will adjust a lot of the time. Um, but over time, you're going to get this change in function. And sometimes people, when the death actually happens, it feels like a shock to them. And I've sat with many families that need kind of debriefing around this change in function. One useful thing I've always done is I always ask people to show me a picture, like when was dad the best he was, like when was he really himself? Show me a picture when he was totally himself, that he didn't, none of this was happening. And it's, people will take you back often years to that picture. And then sometimes I'll be like, well, can you show me a picture, like did things really change for your dad, like, and people say, oh, when he broke his hip. So we start looking at stepping back from these trajectories to help people process. The last one, dementia. My mom had dementia. She lived well. I would say my mother lived some of her best life with dementia, truthfully, but she had for about 10 years, and in the last part of it, the last couple of years, she started to fall. And this is something that happens with dementia trajectory quite a bit, that's good to understand and notice, particularly if you're downstream from hospice, is when people start having sort of what we call maybe the dwindles, where their reserve to deal with other problems become less. So you're always want to look at people's reserve. They might get through a pneumonia, but how good is their reserve? Is it creating dwindling? My mother's case, she just fell, and eventually she had a fall that ended her life, after about 10 years of caregiving and having very, very good periods and not so good periods in her life. So it's just sort of ways to think about this. Dementia patients will often die of an infection, an aspiration pneumonia, or the RSV, the COVID, the flu is actually the thing that tips them into death. Okay, so let's go to the next slide. If you guys have questions about this, just put them in the chat and we can get it at the end. Or, you can also contact me if you have comments or questions as well. So when does the disease model help the most? It really helps when you combine it with function to come up with prognostication. And this is sort of what doctors use in order to decide if people are hospice ready, even though it's still pretty tricky, as I'm sure people on this call know, like actually making that call can be pretty tricky. And that's why hospice tends to be a very last minute thing. It can be hard for doctors to put their signature on the paperwork saying that someone has less than 6 months to live. They don't even have to say a few days, less than 6 months. Um, okay, next slide. So we're going to get to question 2. Um, so when is end of life most appropriate? So I gave you the answer at the beginning about there's no magic time, but in some ways you can use this functional model, these models to kind of decide. So when you see your patients having what we call end of benefit of treatment, it's starting like it just isn't working as well as maybe it did the year before or the week before. And then you combine that with function. And function, so function is a really big part of this, in terms of deciding when it is that you really want to step in and try to do some work with a patient around this. Okay, next. So I'm going to shift gears just a little bit. I'm going to tell you about one of my favorite books because I really like the way she reframes what she calls elderhood. And I just think it's a much more life affirming way to see what she says is the act 3, the third act of people's lives. And she kind of defines that as something loosely starting in your 60s to 70s, to 80s. It's a very big time in her opinion. And I really recommend this read. It's a really good read. Next slide. Okay. So let's just look at this a little bit more closely. So what she is sort of arguing is that the time elderhood is this very vast time in people's lives that you can't kind of there's no magic. Like we tend to think of 65 and then you enter into this void of like seniorhood. And we tend to think of it as one thing, and that there's a lot of reasons for that. It has to do with when Medicare kicks in and a lot of cultural things around aging that tend us to think of this as one thing. If you go back to childhood, for instance, what she's saying is that your health, appearance, and function are very varied at this time in your life. So if you go back to childhood, and you look, let's say, at your normal average toddler that's meeting benchmarks, like seen one toddler, seen them all to some degree. But if you look at a 65-year-old or a 75-year-old, their function, it can be vastly different from person to person what their function. You can have a 65-year-old that's out on the slopes that has a full-time job. You can have that person, and then you can have someone who has multiple chronic illness who's homebound. And just the range is huge. And then as you age, that range can be all over the place also. So you really have to pay attention to the person right in front of you before you jump to kinds of assumptions about what they need and what they need. You really need to do that. And that to me, it's a lot of it is just finding out about them, basically. And I'm going to apply this also to hospice for hospice people as well. So let's keep going. All right. We can skip over this. It's just another quote that I like from her book. And she talks about sort of the magnificent time of her Act Three. And I just think it's a much nicer way to look at this period in one's life. Okay. So let's go back to Carlos. Does anybody think Carlos is at end of life? Do we think we should have an end of life discussion? He's 75, so if you're using in the numbers game, you would kind of say maybe, yeah, sort of, but maybe not, and the best way to find that out is also to find out about what his function, which is what's missing here, right? I didn't do a functional history on for Carlos, so we're going to just talk about that a little bit, about what kinds of things someone in their last act need. So you can go to the next slide. All right. So what are what I'll call these intersecting interventions for all what we'll call Act Three patients? That's anyone in their 60s, 70s, 80s, 90s. So it doesn't matter where they are in the so-called end of life trajectory, but these are things you can think about for anybody. And this is true for anybody, no matter how old they are, but it really particularly applies when you're starting to work with people, older adults. So there's the proxy. I'm not going to talk too much about power of attorney for finances. It's a whole like other talk. But it's so, so important. I know in my mother's case, it was really critical because she had dementia and she really needed help with it. It took us like 5 years to get her to like sign like a power of attorney for finances, like kind of a nightmare, but it's really, really important. But let's go to the next slide. We're going to start with function. So here are just some examples of some functional assessments. I'm going to tell you, I'm going to be so honest with you guys that I really never used any of these myself. I particularly was adverse to using them when they were mandated, so I particularly didn't use it if someone told me I had to use it. But in general, I think the place to start with anybody is really just to ask them about their day. So if it's someone who is working, who's active, who's maybe 65 or 70, who's doing lots, it's just say, how's work going? What are you doing? Is there anything that you're not able to do to have fun that you used to be able to do? You can ask functional questions in a kind of life affirming, for people that are very vigorous and they're actually healthy. You could do it that way. And then for people that who have have multiple functional problems just by meeting them, I would do a lot, and I did this with hospice patients too, because it's really useful for hospice patients. Is I would just have them tell me about their day. We'd start at the beginning. Tell me what you did today. Did you get up? Like, what time did you get up? What'd you have for breakfast? Did you take a nap? How's it, like, what was your favorite food? Like, I just have them walk me through their day. It's a really good way to get really great functional information. And it can be fun. You can have some hilarity in that. You can bring in people's caregivers. It can be a really good way to find out about people's function. And even for hospice patients, it's super helpful to understand that, without sort of just doing it in a kind of very like administrative way where you've got a sheet and you're putting checking boxes off while you look at a computer. It's sort of a less helpful way to, I think, to engage with people. So it's just something to keep in mind. I know all these questions. I encourage you to look at these functional assessments, and the more debilitated people get, the more relevant these particular functional assessments will get. Okay, we can go to the next slide. So I want to talk about interventions for all Act 3 patients, and I'm gonna start gearing it towards hospice first, and then we'll work our way back to patients that are not on hospice. But fall prevention is so important in a hospice patient, so important. You can just totally wreck somebody's end of life by having them take a terrible fall, and it can happen. I mean, and if you're in it, you'll know the chances someone is going to fall. You get the person who's trying to, who's a little bit delirious, who is trying to get to the bathroom on their own. That would be a classic way, and they're wobbling around. I know my dad, when he was dying, had a really bad delirium, and in addition to being a little dignity stripping to remember this about my dad, like for him, like, but I just remember finding him wobbling around and like, actually peeing on the carpet because he just couldn't get to the bathroom. And you just it's just you don't I didn't want my father to fall, and that's all I thought about at the time. But also, it was we weren't paying enough attention to his safety that way, and then he ended up in a kind of dignity stripping situation for him, and then also we got really scared. So it's just something to think about, to train volunteers to recognize fall risks also, so that if you see something, you can report it up the chain and say, I'm a little concerned there's not enough lighting, or this person seems to be able to escape out of their bed really easily. They got a leg over, an arm over, that kind of thing. um, so it's really good to stay aware of that. Fall prevention, even for younger third act people, like I'm on the sunny side of 65, but I will tell you that I think about falls quite a bit now, because I just know that um, falling at this point is going to really, it can really be sort of life changing, for a young third act person. And so you want to just, falls as a really good way to intervene. Dental care is another thing that can really go off the rails that people don't think about. This is particularly true for patients with dementia who just simply forget to brush their teeth, or they do such a superficial job that they end up having all kinds of dental problems. We had a really big problem with my mother with that. Like, she just wouldn't brush her teeth thoroughly, and you really need to be able to work with people to remind them about good oral hygiene. And for hospice patients, when we used to do those rounds in our unit, and I did this all the time as a palliative care consultant, first place I would go is to look in people's mouths, because people would just, the other teams would just not do it anymore, and you would get thrush and sores, and it can be a real source of suffering for people. So being paying attention to people's mouth care at end of life, and also before that, if they're not really brushing their teeth properly, it's just a really good way to intervene at any time in the third act. And then eye care also is another thing, in terms of fall prevention, but getting the glasses and getting people the cataracts out, anything you can do. These are things that they're not specifically end of life, but they really can make a difference on how people move into these times, taking care of these basics for them. So primary care really matters for older adults. Okay, next. Okay. All right, so we're at the sort of the climax of the talk, with talking, how do you actually open up these conversations with people? And it's never easy. I've had thousands of them, honestly, and I can't say that they've ever been easy to have, but it really does help to have some strategies that you can rely on. And so that's what we're going to talk about in this section, and then hopefully there'll be some time at the end to also answer your questions about this. So you can go on to the next slide. So I will argue that a healthcare proxy, filling out a healthcare proxy with a patient is a really good way in general to enter into the bucket of advanced care planning. You know, a healthcare proxy is not just for older adults, but when you sort of entering third act, it becomes more critical to have that. Each state has its own, well, they're usually advanced directives is a big word for it. It's usually involving a living will and a healthcare proxy. I'm going to really focus on healthcare proxies for this talk and not so much on living wills. So go to the next slide. So just a couple of words about living wills. I mean, you know, the time living wills are the best are really for patients that have what I'll call a movable beliefs that are going to stick with them no matter what's happening, and meaning they have a religious, personal, or cultural belief that's very, very strong and informs everything that they do. Like, for instance, I've had patients who are Jehovah's Witness. That's used tends to be something that guides every decision moving forward for patients. That's a time when it's great to have a living will, and they can say, this is very, very important to me and I want it there. And I've had that, and that's better for them when it's written by them in a living will. The time where it gets tricky is, you know, the truth is many of us can change how we feel over time. And if you, it can get tricky to have a living will. And I've been in situations in the hospital where, you know, you have a living will and then you have a family saying the exact opposite, and there starts to be conflict. That's when you have the lawyers and the ethics committees and the rest of it. It's when I would get like really sweaty. So when I'd have to deal with these situations, because, you know, it usually involves a lot of anger and conflict and stuff like that. So sure, you know, living wills are okay, but it's not where I tended to put my efforts. I tended to put efforts into healthcare proxies with patients. So next slide. So I think the best way to understand healthcare proxies actually is just to do one yourself. Everyone, we all should have one. If you're over 21, you should have a healthcare proxy. I made my kids do them. They're both 30 and 30 years old. I made them do a healthcare proxy. I have one, but they're very specific to the state you live in. So one way to find out about a healthcare proxy is to do one yourself in your state and learn about it, because then that's going to help you with your patients, and it's going to help you feel comfortable with doing them. You really, this is an example of the New York State healthcare proxy. Um, I, I'm not exaggerating. I think I've done like, I don't know, several hundreds of them over the years. Um, and you can go to the next slide. And you know, so every state has different kinds of ways of approaching healthcare proxy. So you can one state's healthcare proxy is one state's healthcare proxy, but you really don't need a lawyer to fill out a healthcare proxy. The thing you want to be careful as is that you ask them if they already have one, because you don't want to get in a situation. I've made this mistake where, you know, you have daughter one is on the healthcare proxy, and then the patient fills another one with daughter two on it, and you've just created this huge, you just stepped in it big time, you know, with a family where you created conflict over who's the healthcare proxy. So you just have to be careful, you know, to make sure you're asking the right questions. But a healthcare proxy is something that can be done in a primary care clinic. It can be done in hospice, honestly, but you know, you just want to make sure you're being careful and you're asking the right questions about it. So next slide. So these are some of the myths that, you know, it's you just do them when you're over 65, that you need a lawyer. It's really expensive to have a lawyer. It's like, I want to say it's $5,000 to have uh, at least, depending on what state you're in. But you can print them out from the web. Every state usually has a site where you can print them out. You don't need a lawyer to do at least a healthcare proxy. Sometimes living wills, depending, they're better to have a lawyer do with you because they can be complicated. Power of attorneys, it's hard. You can do power of attorneys without a lawyer, but they're simple ones. But when you're doing something complicated, then it tends to need a lawyer for that. Um, and the biggest myth people have about healthcare proxies is that you're kind of like handing over your decision-making right to somebody, and that's absolutely wrong. And that's the part you want to make sure you're really clear with patients, that the healthcare proxy kicks in only when the patient can no longer make decisions for themselves, or they've said, you know, ask my proxy, like they've actually had the agency to say, I want you to talk to my daughter. I don't want to talk about this anymore. Something like that. That's the biggest thing that you want to make sure that people, because it's what stops them from doing them actually, is because they think they're handing over their right to make decisions, and it's just not true. And even my mother with dementia, we included her in most things. Like we didn't bypass my mother for most, even though even when she had advanced dementia, we didn't bypass her. It's just something to remember. Okay, next slide. Okay, we're back to Carlos. We're gonna use Carlos as an example for doing a healthcare proxy. So if you look at his life situation, we're just gonna think about what the issues are with him. Okay, um, let's go to the next slide. I use a lot of diagrams to do social network diagrams because it just helps me. So in this case, you have the sister, you have three potential proxies really in Carlos' life: his domestic partner, his adult son, and his sister. And depending on the state, a domestic partner can mean something different depending on the state. In New York State, they count just as much as a spouse, I believe, but that could be different. For people that are living with a partner, it can be in some states it could be really critical to have if the person wants them to be their proxy, it's really important to have that person on the document because it just depends on the state you live on. So go to the next slide. And I'm just going to skip over this one for now. Okay. Because I really wanted to get to this section, which is the last section of the webinar. And it's really someone's saying for me to speak up. Can you not hear me?
Yeah, we can hear you.
Okay.
It's always nice for you to be close, but yeah, no major.
Yeah, okay. I'll try to get closer. But yeah, if it's not good enough, just tell me guys when if it's not. All right. For a healthcare, for the conversation, I would just want to give you some tips on how to approach this. And I'm going to say that about a year ago, I did a series with Nice about how to have conversations. It's a four-part series, and these slides are from that series. I know that Nice is going to have it on a new platform, and it will be sending you an email about how to access this material. But it's I think it's really good in a more detailed way than we're going to do today. Um, but um, but I want to encourage people to go into that series, and it's like 10-minute episodes, so it's not terribly long. And I want to talk about this idea about signposting because it's just a super good way to get into a conversation. So let's just go to the next slide. Okay, you can put up the first. Okay, so pretend you're the provider and you're saying, "May I put something else on the agenda today?" Now, what that is asking permission. Asking permission, it's really important to do that. There's lots of reasons to do it. One, it's respectful to your patient to ask permission to talk about something. We tend to blow in rooms and we have agendas and we just forget to ask, this is something I want to speak to you. May I go ahead and put something else on our agenda? It's just a good way to give your patient agency. Also, so they can get off the train that you're starting, they might not want to have this conversation with you right now. And it gives them a way to have some agency in a conversation that's, I think, really important for an end of life discussion. So let's go on. Caller says yes. Okay, so this is the signposting. An important part of future care planning I just have to move the thing here, um, is identifying someone to make healthcare decisions for you if you couldn't. So that's the signposting. It's sort of telling the person what you want to talk about. And you can go to the next. And then here's the permission again. So you're saying, may I explain further? So you go from signposting to permission to signposting permission. In palliative care, we sometimes call it a deep dive where you start up here and then you ask permission, you give a signpost, you deal, then you go down again to another more deeper complex thing, permission, permission, permission. It's just a super good way to move forward in a conversation. And be prepared that the person just might not want to have a conversation. And that's okay. That's okay if they do that. You can put it on for next time. Okay, next slide. Carlos says, no one has discussed a healthcare proxy with me. Next. And the provider says, it's normal not to have discussed it. Most people don't. This is something I discuss with all my patients. So it's a type of signposting where you're normalizing that we all do it. And then you can go further. Next. And then again, permission, could I take a minute to explain why it's worth thinking about? And the language that I'm going to suggest that you try to avoid if you can is you need to do a healthcare proxy. You should do a healthcare proxy. Those need should words that we can go to because we really might want that patient. The other really no I would say is it's our policy of our organization for you to do healthcare. Like you want to avoid the policy word as much as possible. I know for me, like if somebody were to say that, like I would probably just like leave. Say it's our policy that you do this. Um, so it's just should, need, should, you must kind of words. You want to try to avoid those. Just ask permission, see what they say. It'll make you, it equalizes you with the patient, so you're not like a power over them. Okay, next slide. Yes, go ahead. Next slide. And then who do you trust to make decisions for you if you're unable to? And that's a careful phrasing because it's emphasizing that the issue of trust, because that's what a proxy is, and then also that it's when they're unable to, and you just want to make that clear. And it's hinting to advanced care planning, it's hinting to end of life. I mean, people are smart. Even if you say you're unable to, sure, that can be if they broke their leg, they're unconscious, they got hit by a car, it could be that kind of situation. But more often than not, it's when people have started to move to the point where they're having trouble making their own decisions because they're really, really sick and they're moving towards end of life. That's usually when healthcare proxies come into play for the most part, not always. Okay. And this is just some more language. I know for me, when I was starting to work as a palliative care doctor, I actually memorized a lot of phrases because I was scared. So here's just some like wording. Who are you most comfortable speaking with about your health? Who is most involved in your care? And then this one about who can you trust to make decisions for you if you cannot. These are just words to have like in your pocket in terms of opening up a conversation with people. And next. Okay, so then what happens in Carlos' case is he decides to name his domestic partner, Julia, as his primary agent and then his son as his secondary agent. And you fill out the paperwork with him. Okay, next slide. And this is also really important steps to get bypassed with proxies. But it also gives you another way to get other people involved. Because if you're looking for a way to enter in, because most people, if you're talking about hospice care or home hospice, there's got to be other people. There's usually a caregiver or a spouse or somebody, and eventually you're going to want to bring them in. So this is another good way to bring people in. So you're going to make a copy if you can for Julia, for the son, maybe for the sister, and for the health center, right? Or for wherever the organization that you're at. And then it's the patient who keeps the original. Some people think you keep, no, it's the patient's document. And that's another way to signal to them that they're in control of the situation. They can just rip it up if they want to, it has to be a document they have power over, right? And then this is when you can start moving into next, these suggestions to bring other people into the conversation. It's another good way to do it, especially where it's a little bit sensitive and you're kind of walking on eggshells with a particular patient. Um, to offer to meet with Julia and the son to discuss the role of the agent, which is actually very important. And then that's a way of moving in towards difficult discussions that's a little less threatening, and also just very important that a proxy actually knows they're the proxy, and you can mediate a conversation about somebody's preferences or wishes. You can go from there. So I'm going to stop. It's 2:48, so I'm going to stop to see if people have any questions for me or the team about all this. So we're going to open it up, see if anybody's got questions.
Thank you so much. Yes, please do use the chat or the Q&A. And while folks might be thinking, I wonder, Dr. Hellerman, if you mentioned this briefly, I think in reflecting on your mother's journey and your how you and your siblings were caregivers in different capacities, and I know in our past activities we've had a lot of caregiving conversations, but would love even like a little bit more insight from you on Now, certainly, you just ended with saying there could be once a healthcare proxy has been determined, maybe there's future conversations to be had with said proxy who may or may not be an informal caregiver. But any reflections that you have on just the importance of informal caregivers in general for older adults and thinking about um, function and not knowing exactly when end of life is for them, but wonder if you could give any reflections on how, there's some folks coming in this session from a health center setting, some from a hospice setting, there are a lot of different settings, but just curious any other thoughts you have around caregiver support and engagement.
I mean, I think one really important place to start when, especially if you have a caregiver that's coming to visits or you're in a hospice situation, is really just say what's working here. Start with what's working well. We tend to forget that. We tend to go right to the problems. Um, but ask someone, tell me what's working well and how I can support it. I often will try to start from there rather than tell me all the things that are going wrong. And because some people won't tell you that right away. It's because it's a little bit, it could be a failure thing. It could be a control thing, a lot of things. And I think it's much better just to start with tell me what's working and how we can support it. I also think is particularly with hospice patients, there's so many ways to work on just helping them with the little things that can open up trust and conversations and humor that allow some of these bigger conversations to have. I know that when I think back on all the times I sat with people that were dying in hospice, the biggest thing I didn't really do anything special. I just kind of sat there. And it's amazing that if you just sat there and you don't take up too much air with your own words, because sometimes we get nervous around people that are dying and we want to fill up the space. With our words, and we don't leave enough room for them pausing, because sometimes people, particularly hospice patients, sometimes a mentation can just, it's not that they're not mentating, they just take longer to say things, and we can jump in and kind of fill up that airspace. And so I would say, if you're a volunteer, if you're sitting with someone, um, to find ways to be present without actually necessarily being the one doing all the talking, and to take the person's lead. And with caregivers also, just to make them trust you, that you're on their side. You're not going to you're not going to be too like ordering them around, telling them what to do. Most caregivers really, that you're really not listening to them. Those are things that usually shut down caregivers, and it's just a good place to start with that.
Wonderful. We do have two questions in the chat.
Okay.
First is wondering if you have any hints around introducing the subject of a healthcare proxy when a patient is a family member.
Oh, your own family member.
It's what it sounds.
Oh, wow. Okay. It's just like talking about torture. Okay.
Yeah.
It can be really hard. I can, just having done both. I found it actually much harder to do stuff with my own family than I did as a professional. And sometimes those professional hats that we wear kind of deteriorate. Like, I would sort of fall into whatever role I was in my family situation. So it can be hard. I would say, the the way have tried to approach things, with my own family, is to understand that I can't control my family and I can't control their actions. You have to start with that, like you really do, because we sometimes, as a professional, you really know what they need to do, and it can be so super hard. To back off of that position and just be a listener, and wait to give your advice. I mean, we're fixers. I know that I've struggled with this myself. Like, I want to fix things because I see the answer because of just all the years of doing this, and I really had to learn to back off of being the family fixer in that way, and just to be there. And if they ask me for my help, then to offer it, but to not step in as a fixer. And even that's true even with a healthcare proxy. I mean, there's some subtle, you just have to use your wiles and guiles to get family members to do things like that. Tricks of the trade that is going to get your sister interested. You probably know them better than you realize. And if you approach it, you just have to think about it. And then sometimes it won't go well and you'll fail, and just accept that and know that if your heart is in the right place and you're not being a know-it-all, then it'll probably be fine. But it is hard. I don't have like a really clear answer about that. There's one way.
Yeah, it sounds like potentially some difficulties to navigate. And maybe if it's
Yes.
not like you said, Lynn, in the little example exchange, you had said maybe someone will say, "No, I don't want to talk about it today." And you say, "Okay, like maybe we'll talk about it next time." Maybe there's a next time, for
Right.
sure. We have a
Right. You have
question.
to do that. You have to be willing to let go of that. That can be more effective to get someone to come back to do something than trying to push something on someone too hard.
We do have one more question that's about once a healthcare proxy's already been established. This individual is curious if you have recommendations for having conversations with a healthcare proxy. This person writes that not everybody realizes that save them no matter what is not always the best option when a person is in a lot of pain and cannot recover from their ailments. There's a lot there.
Yeah. Well, that's like a two-part question. But the first, in some ways, I would say you always, one thing, just this is so important, is that if you're going to have a conversation with a patient and let's say a proxy or a caregiver, that the patient has to be the one to move the conversation, because you can have a situation where you'll have a family member talking for their adult parent, or they're talking because they're used to it, because they're the ones they're doing great work, and you should always be acknowledging caregivers' importance and the great work that they're doing. But at the same time, if I'm sitting with a patient and a proxy at the same time, or a caregiver, I will look at the patient, and let's say the proxy were to say, I'm really worried about all this pain he's having, and he's not like accepting what's going on. Like they're kind of not there. Like the patient's not there. He's not accepting what's going on. And I'm really worried about this pain. Like if they're talking to the provider and the patient's sitting there, I will almost always kind of look at the patient and say, hey, your daughter is really concerned about, I'll repeat it, they're really concerned about the pain that you're having, and also about what's happening to you right now with the cancer. Is it okay if we talk about those things? It's that going back to the permission thing, and you're asking the permission of the patient. Okay, you want to just center towards the patient. Sometimes if it's clear that a patient can't handle it, I will ask the patient. I'll say, hey, I know your daughter has a lot of concerns, you know, and I really like to be able to spend some time with your daughter and talk through these things. Would it be okay if your daughter and I spoke separately about that together? Would that be all right with you? Most people will say yes. Sometimes they'll say no, and you have to accept that, but it's a respectful way to the patient to keep them centered and to always ask permission, particularly because you can be really drawn into conversations with caregivers because they can be upset, they can be angry, they can be anxious, there can be urgency, and you can find yourself swept into these things very quickly. But you always want to just pause and just say, who's in the room? Who do I have to ask permission? And go from there, and that will help you. Even with these difficult things about not accepting a situation.
Hmm. Thank you for that. We are just about out of time. We don't have any other specific questions, but Tiff put a lot of helpful links in the chat, including if you want to hop over to Dr. Hollerman's website. You can contact her there if you have questions. You can also send us an email. We're happy to pass that along as well. Tiff also put links to our webinar page if you want to check out additional learning opportunities. Also, the link to our evaluation survey. Like I said at the beginning, it's always helpful to get your feedback on what went well, what you might have wanted to add or do differently, so we can consider that when we're putting together all sorts of new activities for you. So we really appreciate everyone's time. Dr. Hallerman, thank you so much
Well,
for
thank you,
your
everybody, for
insights and
showing up.
expertise. Hope everyone has a wonderful rest of your day, and we hope to see you back at another learning opportunity very soon.
Okay, bye, everybody. It was a pleasure, really.
Thank you.
Bye.